Hey everybody, we've got another specimen today. This is number 72 in our collection. The heart would have sat roughly in the chest like this. Anterior surface here, posterior surface towards the turntable, superior head up here, inferior legs down here, left over here, right over here. Now let's try to find the right atrial appendage, at least externally, as we usually do. And when we do that, we see that, in fact, much of the atria have been dissected and removed. So here we do see the left atrial appendage, so we're going to assume that the right atrium would have been here. So let's begin by looking down at this heart now, and I've kind of reoriented it, so now the anterior surface is towards the top here, posterior down here, and this appears to be where the right atrium would have been. And then this would have been where the left atrium would have been. And we can tell that by the left atrial appendage, which is here. And we know this is the left atrial appendage because all of its pectinate muscles are confined within the appendage itself. None of them spill out. But as we look down at this atrioventricular junction, we see immediately that there is a common atrioventricular junction. So we are looking at a heart with an atrioventricular septal defect. So let's look at this from the right side first. And when we look at it from the right side, we find the inferior bridging leaflet, which courses over the top of the crest of the ventricular septum here. And so here is the inferior bridging leaflet. And then we look at the superior bridging leaflet here. Now let's look down at this superior bridging leaflet. So here is the superior bridging leaflet. Here's the right component of it. Here's the left component of it. And here's the crest of the ventricular septum right here. When we look at the crest of the ventricular septum, we find that there aren't any connections of the superior bridging leaflet to the crest of the ventricular septum. So once again, here's the crest of the septum, here's the superior bridging leaflet, and there are no connections to that crest. In fact, we find that the superior bridging leaflet courses over the crest of the ventricular septum and then ultimately has connections to some papillary muscles that arise from the free wall of the right ventricle. So here is a papillary muscle arising from the free wall of the right ventricle, and here are the connections of the superior bridging leaflet to that on the right side. So there are no connections from the right side of the superior bridging leaflet to either the crest of the septum or the ventricular septum itself, which is in line with what we would call the Rastelli C if we were to use the Rastelli classification. So once again, just to make that point again, here's the superior bridging leaflet, here's the left component of it, and then here is the right-sided component of it. Here's the crest of the ventricular septum. No connections of the superior bridging leaflet to the crest of the ventricular septum. In fact, its only connections are to this papillary muscle here, which arises from the free wall of the right ventricle. So consistent with what we would call a Rastelli C. Now, the ventricle itself does have coarse trabeculations. There is a septomarginal trabeculation here, all consistent with the morphologic right ventricle. And then as we get into the outflow tract here, we do find a 3-leaflet, 3-sinus valve that has entirely muscular support consistent with a pulmonary valve. All right. And the pulmonary trunk has been transected here. Now when we flip this heart to the back, here is the posterior surface of the heart itself. So we know the atria have been largely removed, but here is the left atrial appendage externally, pointy, finger-like, and all of its pectinate muscles are confined within the appendage itself. Here's the left-sided ventricle, or more accurately, the more posterior ventricle. You can see fine crisscross trabeculations consistent with the morphologic left ventricle. Now, when we look at the common atrioventricular valve from the left side, here's the superior bridging leaflet, which we've looked at in detail. Here's that crest of the septum. And then here is the inferior bridging leaflet here, coursing over the top of the septum. And you can see that the inferior bridging leaflet does have connections to the crest of the ventricular septum. But now when we look at this, the superior bridging leaflet from the left, we see that there's no direct connections of that superior bridging leaflet to the crest of the ventricular septum, which we've already appreciated before, but we'll highlight once again. You can also see the scooped out appearance of the ventricular septum due to the atrioventricular septal defect. And also, another thing to highlight is that the inlet distance of the left ventricle is in fact a little bit smaller than the outlet, the distance of the outlet component. So here is the inlet component, here's the outlet component, and you can see that the inlet component is in fact shorter than the outlet component because of the anterior kind of springing forward of the aorta now that it cannot be wedged in between the two atrioventricular valves, since there aren't two atrioventricular valves, and there in fact is a common atrioventricular junction. Once again, you can see the scooped out appearance of the ventricular septum here because of the atrioventricular septal defect. Here's that springing forward of the left ventricular outflow tract, which leads to the unequal inlet and outlet distances of the left ventricle. And then here we come to another semilunar valve. There are 3 leaflets and 3 sinuses. Here we do see that there is fibrous continuity between the semilunar valve or arterial valve and the left-sided component of the common atrioventricular valve. We do see coronary arteries arising from the sinuses of this arterial valve, all consistent with the morphologic aortic valve. So here we have a heart that would have normally arranged atria with a common atrioventricular junction, with the superior bridging leaflet having no connections to the crest of the ventricular septum, but rather having connections to the papillary muscle arising from the RV free wall, consistent with what we would call a rastelli type C. There is right-handed ventricular topology, and there are concordant ventricular arterial junctions or connections, all consistent with an atrioventricular septal defect. And the atrioventricular septal defect, it's hard to comment if there would have been a large atrial and ventricular component, but certainly there is a large ventricular level component to this atrioventricular septal defect.